Hello, and welcome to the HSJ Health Check Podcast. I'm Annabelle Collins, and this week I'm joined by HSJ editor Alastair Mclellan and fellow senior correspondent Nick Carding. This week on the podcast, we are turning our attention to what the restoration of the NHS in a post-COVID world could look like. Alastair's leader article, published earlier this week, focused on what the next 6 months could hold for the health service and set out various predictions. I think, first of all, it would be helpful, Alastair, to take listeners over the main points you discussed in the piece.
Hello, everybody. I hope you and yours are all well, and that whatever endeavour you're involved in is going well in these challenging times. So HSJ has deliberately avoided making many predictions about the COVID world and the post-COVID world on the basis that events have been moving so fast and the factors have been changing so significantly that we thought it was right to devote our resources to covering those rather than speculating about the future. But we have the privilege to speak to most of the most senior people within the health service, and I thought it was time to try and pull together the conversations that I and colleagues had had into some kind of sense of a roadmap for the service going forward. There is a range of pressures on the service, on the NHS, to begin to increase the amount of what we'll call routine work. Often it isn't routine, but I think you'll know what I mean. And both from the government and particularly from charities. The many patient charities are all perfectly understanding lobbying for their services, for the services that serve their particular group to be brought back on line as quickly as possible. A lot of people in the service are nervous about that. They fear false expectations being created that the service will be able to return to normality much quicker than they think it will. There are different levels of nervousness at different levels of the service. I think it's worth, before we plunge into talking about the factors that will impact on the service's return to normality, to just think, which are largely about capacity, though not entirely about capacity, is also to think about demand. The big unanswered question, the question that still is really to be unanswered, is what demand will look like in the next 6 months. Will it return to the same level as it existed in January, February, adjusted for seasonal variation? For example, with emergency A&E attendances, we saw a massive drop-off in attendances, about half of which has come back now. But at the height of the drop-off, as could reasonably be expected, but still interesting to know, the proportion of minor attendances that weren't happening were 14-1 compared to those of major attendances. So obviously the major attendances will continue, but will the minor attendances return, or have, because of this, because people didn't want to go to an A&E, has that flick some kind of switch in people's head? With elective referrals, obviously they've been down significantly, and there is significant reason to be worried about that in a number of areas. But for as long as I've been HSJ editor, and I first became HSJ editor in April 2002, I have been told, for example, that a significant proportion, the percentage depends on who you're talking to, but a significant proportion of patients in orthopedic wards don't need to be there, and that with a better provision of physiotherapy or earlier intervention in some kind of way, that they could avoid operations. Now, it may or may not be true, but orthopedic surgeons have told me that. So, I think it, and they love to operate. So it probably is true. And now that you'll go as a referring clinician, that when you refer someone, you're putting them on a waiting list, particularly if it's a condition which is not going to be treated in any kind of emergency way, that you might be putting on the waiting list that is, 9 months, a year, who knows where we might be in the autumn period. And maybe that's an added incentive to explore other ways of addressing that particular concern. And of course, if they do that, then the waiting list isn't so long, and so maybe the behaviours don't change as much. But I just wanted to stress how a lot of people at the centre are looking at these predictions of 10 million people on the elective waiting list and going, hold on a second, that depends on whether demand being what it was before the pandemic. Maybe it will, and whether all follow-up appointments, for example, are followed up actually, when we know that many follow-up appointments aren't necessary or could be handled in other ways. So sorry, bit of a ramble to begin with, but I think it's important contextualization. So I thought I'd talk about the return to normality, whatever we want to call it, the reset, the NHS Confederation calls it, in 4 areas. The importance of the testing programme, changes in staff roles and behaviours, with an emphasis on infection control, and the change of service models. And then very briefly at the end, we might talk about some of the broader policy legislative changes that were set up in advance of that were in process before the pandemic came around, and may now be significantly influenced by the pandemic and what has happened. So the testing programme. The testing programme, and I want to stress here, I'm talking about the tests rather than the tracing. The testing programme, its comprehensiveness, its efficiency, speed of turnaround is very, very important to the speed and the nature of the return of the NHS to normality. The more tests that are done, the better the quality of the warning that the programme will be able to provide to the NHS that there has been or there is about to be a spike in coronavirus cases. The more granular they can be around pinning it down to particular groups of patients or organisations or areas. And that's important because the more sensitive the testing programme, the less capacity they have to hold in reserve, and the fewer services that are displaced by having to hold that capacity in reserve. And that reserve capacity is a sort of it exists in two sort of elements. One is a sort of rough rule of thumb. We need to keep 10% of beds or whatever, etc., available just in case. But it's also a sort of on a more granular basis. For example, in parts of Southwest in Cornwall, Dorset and Devon, there are almost no COVID cases at the moment. Or sorry, there was no people in hospital with COVID. So in theory, you could absolutely release lots of capacity there, but we have seen in past that around the areas around Bristol, there have been some. There was in Western, of course, there was an uptick. So probably Devon and Dorset a bit too far away, but you get my point. You might need to keep capacity in reserve in an area which has relatively low COVID load to help out a neighbouring area that might have a higher COVID load. Maybe we'll see that with what's happening in Northamptonshire at the moment. So the more granular the testing is, the more you're able to make both choices at a sort of national level. What is the sort of benchmark reserve capacity bit, but also the more flexibly local that you can be. And perhaps, Nick, it's a good time to ask you sort of where we are on that question about the testing program. What is the level of activity going on at the moment? And also perhaps what would be particularly interesting to know is there's been a rush for numbers, as we have reported over the past, as opposed to a sort of careful attempt to get something which allows you to build a system which can be used for reporting and analysis.
So basically, where we are with the testing program, currently testing capacity as of the latest update stood at about 220,000 tests. But interestingly, the number of tests that are being carried out is dropping. For the last 5 days, it's been dropping down through the sort of from 160,000 to 105,000 yesterday. So clearly there is a lot of capacity and not that many tests being carried out, which is interesting in itself. So there's really two things I think just of note that I'll talk about quickly. The first is that the NHS has been asked to increase its own PCR testing capacity. So those are the tests that are carried out by taking swabs and samples from patients. So previously the NHS, or currently, sorry, the NHS is doing around anything from 30 to 40,000 of these tests a day. The new ask is now to do just under 90,000 tests a day, which represents quite a big increase in capacity. And I think there's a sort of a realistic expectation among national leaders that not all labs will be able to achieve that. But in asking labs to try to achieve it, they'll be able to better identify which labs aren't able to get that, to achieve that capacity, and so they can focus their attentions on those labs specifically when it comes to supplying them with reagents and other pieces of equipment. So that's that'll be interesting to follow how that goes. And then the second thing, which I think is interesting, is that we're now seeing a much more sort of targeted approach, which is away from getting just the numbers up, and it's more about getting the right kind of testing into hospitals. So, you know, you've got the PCR tests, which currently are being turned around in around 12 to 15 hours in labs, but there are now very strong efforts being made to try and increase that time much faster, so that you can turn around tests in anything from 1 to 4 hours, and that's going to clearly have a massive, potentially massive impact on patients emergency patients, being able to test them to make sure that they're COVID negative or COVID positive. There's also work going on to deliver tests that don't require processing in labs, tests that can sort of give you the result within half an hour, if a bit like almost like a pregnancy test is the comparison one person told me about. You can sort of just provide a sample onto a strip and wait half an hour and it will give you the result. So there's much more now focus on getting those kinds of different tests.
So Nick, I mean, the question that was in my mind was, what effort is there going into attempt the testing, rather than simply volume, is actually representative, so that they're testing enough people in each place, so that they could get a good representative picture, because if you just drive at numbers, you could be doing loads and loads of testing in one pace, much more testing that you actually need for the testing part of the sort of analytical monitoring part of it, and other parts of the country could be doing much fewer tests, and therefore effectively the service develops blind spots. And speaking to somebody senior a couple of days ago, they were saying that trust chief executives have been saying to them that those with their own labs felt sort of really confident that they knew what the situation was in terms of coronavirus in their own locality. Those without their own labs, who had to rely on other people to send results back, felt much more nervous and therefore much more cautious in terms of releasing capacity and returning services.
Yeah, so I think that's what this next piece of work is all about, is trying to make sure you get the right kind of tests to the areas that are most in need. So it's not necessarily about giving every lab a blanket numerical target to hit. It's more about where you have potential hotspots emerging. If you start to see a spike of COVID patients potentially, you then make sure you put your supply of rapid turnaround tests to that hospital, because then you'll be able to tell much faster whether or not this is a serious spike and its potential risk of a significant outbreak. So previously up to now we haven't really had that possibility, because the focus has been on PCR tests. The turnaround time has been quite slow, and so you can only respond locally when you have got when you see the numbers coming through. But the way that they're focusing in now is we need to be able to put in place these tests that can be turned around faster, which will help tell sooner if there is an outbreak happening in hospitals such as Weston, which of course was the most recent example, and in Northamptonshire as well.
Okay, thanks very much. I mean, it is the NHS is about to enter what is called phase 3. So phase 1 was dealing with the emergency with all the building the spare capacity in Nightingales. Phase 2 was the initial exploration of returning some services, and phase 3 is meant to be this full-on plan to get things up and running and going again. And phase 3 had begun, was expected to begin sometime in June, or the guidance was expected to go out in June. We now believe it will go out in July, and the reason that it will go out in July is because, as I think Nick has so eloquently described, there's still a hell of a lot to do on getting the testing program to a level where it can provide that robust level of warning that the service needs to begin to release capacity. So the second thing I was going to talk about is infection control. Now, there's obviously a lot. Infection control is a wide-ranging area. I want particularly to focus on staff, the workforce elements side of it. There is, of course, sort of technological side of it, but I thought I'd just particularly focus on the workforce side of it. And I thought I'd particularly focus on it because of the row that was created last week by Matt Hancock announcing pretty much out of the blue that staff would be required to wear masks, surgical masks, within hospitals in all settings, and visitors and outpatients attendees would be required to wear masks, not surgical masks, but masks. And to talk about the staff side of thing at the moment, we had reported earlier, they haven't got much attention, though I used the opportunity of the announcement to bring it back to people's attention, that there is real concern within the NHS about staff to staff infection. To put it bluntly, staff are not now, given that the PPE situation is much better, catching COVID from patients. They're catching it from other staff, and they're catching it not in clinical areas where practice is well established, but in social areas. And so that's one element of the sort of infection control kind of things. The second thing is the sheer, if you're operating in a COVID hot environment, you have to be much more careful with your infection control. And you have to do a lot more deep cleaning, and you have to be taking off, putting on and taking off protective equipment, and etc., etc. And there are certain types of NHS activity, diagnostics, cataract surgery, etc., which are sort of dependent on high activity. It's how they work, and how the rest of the system works. And I just wonder, Annabelle, what your sense is of how ready the workforce are to adopt this new way of working, whether it will be seen as something that needs to be done and therefore people will get on with it, or whether people will see it as something that is an annoyance, and that there may be some sort of shortcutting around it. We certainly have seen that in social areas, NHS staff have not, and there are plenty of reasons for this, I'm not suggesting they're doing this out of any kind of thoughtlessness, have not always observed the social distancing, hence the problem with staff-to-staff infection. But I just wonder, on a sort of cultural workforce behavioural side of things, how you think this new world, the kind of issues this new world might create for the workforce.
So I think from speaking to the workforce, there is quite a lot of frustration in terms of how the guidance changes quite quickly. So, the guidance around needing to wear a mask, even in non-COVID areas, I think there's a bit of kind of exhaustion of having to explain to people why they need to do something, and then it changes and they have to re-explain it. I think people are quite frustrated about that. And in terms of behaviour, I think after speaking to people, it's very, very difficult to socially distance in a hospital, especially if the hospital is slightly older. I think it often depends on the estate of a hospital, how the offices are set up. I was talking to somebody the other day who said that they think their office used to be a cupboard. So it's, people don't have the space to spread out. And if you need to get access to a computer to look at patient notes urgently, or prescribe something, or whatever it must be, you can imagine kind of a queue of nurses and doctors outside to try and get access to that computer, or how many people are allowed into an office at one time. I don't think there's kind of a one size fits all solution to social distancing in a acute hospital, community hospital, whatever it is. I think it very much depends on the space available, how the space is organized, and kind of what the priorities are for staff as well, because sometimes kind of accessing those notes or whatever it might be just can't wait because it's too urgent. I'm not sure how grounded in reality kind of those requirements are.
One of the anecdotes are terrible, but one of the stories that I heard last week was an multidisciplinary orthopedic team having a face-to-face meeting, and they may have all been wearing masks, I don't know, but anyway, they had a face-to-face meeting. They may have all been socially distanced, and they had a face-to-face meeting, and then one of them got COVID, and because they'd met in a non-clinical environment, so they weren't wearing full PPE. So, and then one of them got COVID, and then all of them, or 12 of them, had to go into isolation, and it's that kind of thing that identifies the difficulty of the situation, And I just wonder if you had got any sense that people that within the NHS, that kind of level of awareness of how robust they need to be around, not spending any time together with people that they didn't need to, had sort of the penny had dropped. Because certainly I know at the centre there's a lot of concern that as the test and trace programme pardon me, gets going, and you get similar sorts of situations where people meet in non-clinical areas, not wearing PPE. They may be doing social distancing, but still they're in proximity with somebody for 15, 20 minutes if it's an MDT meeting, and then or the like, and then one of them contracts COVID, and suddenly that's your entire orthopaedics team out of the picture for a fortnight.
I suppose in that situation, yeah, I think the testing would not testing the members of that team, would that not have been kind of quite beneficial into enabling some of them come back to work? But I think from speaking to staff, I think people up until now, people have just been so focused on getting the day job done. And I have spoken to people who said, obviously it is concerning that people aren't really socially distancing at work, but I think it's going to be incredibly difficult to change that behavior. I mean, it's difficult in day-to-day life. We're not programmed to kind of remember to keep that distance from people in queues. Like, you have to constantly remind yourself, and I think it's the same in a work environment, and it's much more difficult in a work environment that really doesn't lend itself to that. I think, sometimes having kind of MDT meetings are really important, and I think it's going to be kind of down to individual trusts and employers, and kind of how to allow staff to have those important meetings, but in kind of the safest way possible. I don't think there's a very easy solution to that.
Well, indeed, and I'm glad you made that point, because that's what I wanted to finish on this particular one. I mean, it sounds like I'm seeking to blame NHS staff. I'm not in any way. I'm just seeking to identify that it is what is happening. Staff are catching COVID from other staff in social areas, and that is a problem. Certainly, it seems to me, and the point we make in the editorial, is that trust chief executives and their colleagues need to be really seriously auditing their space as much as possible, and creating as much ability to social distance as possible. But part of that, I would suggest, is not bringing people who don't need to work, sort of people who are not doing clinical face-to-face stuff, or not bringing them back to work, keeping them working from home, so
Absolutely.
that admin and other areas, it's just fewer people and be more space, and then also providing people who are working face, still giving them the ability to communicate in using technology. And that sort of brings me on to so you can have your multidisciplinary meeting, but you don't all have to go into the cupboard.
Can I just add on the idea about, just before we move on to technology, about kind of very quickly just around not introducing things that are kind of counterintuitive. So I've kind of heard of some trusts closing down the canteen, for example, because they're worried about people sitting too close together. But then that forces everybody to go and sit in much smaller spaces. For example, the mess, which just exacerbates the situation. So I think it's about not kind of panicking and thinking, okay, how do we stop people from congregating, but actually giving people more space. That's something that's just sort of come up a few times.
Yeah, and but we and I imagine Annabelle particularly be very interested to hear of examples of best practice and bad practice too, of how people are addressing this particular issue, because I think we're very aware that people are going to have to sort of rebuild hospitals in terms of services are run, but sometimes physically, at least as a sort of maintenance type level rather than sort of new build type level, so that services can actually run. And the quicker that work is done, the quicker the services can return, because the confidence around reducing staff-to-staff infection becomes greater. There is the whole question of patient-to-patient infection that we haven't really talked about, and is certainly a subject we should turn to in another podcast. So moving quickly on to the technology side of things, I think this is not just technology. It's also moving services out of hospitals into the community, but a lot of that will involve the use of technology here. We have seen, for example, the growth in the use of the Attend Anywhere software on secondary care for outpatient services. We've seen a complete revolution in primary care with the use of digital consultation. What's interesting is how much those services models will be treated as an emergency way of dealing with emergency, or actually something that people were working to and they've just got there a bit faster. Somebody was saying to me the other day, and they were plucking the figures out of the air, as I will, rather than suggesting anything that's particularly true. But if you said, for example, that before the pandemic, 1 out of 10 of every primary care consultation was remote in some kind of ways, virtual in some kind of ways, and now 9 out of 10 are in some kind of ways. Both of those things are not true, but just for the moment, so say, after the pandemic, it's not going, or as we go forward, it's not going to go back. It's not going to stay at 9. It's not going to go back to 1. Now, how do you move to a sort of to the situation where the services that should have moved and were in the process of doing it, and it was just a question of time, do remain virtual, and those that need to be taking place face to face, really need to be taken face, do so in a safe environment. And Nick, you're our technology correspondent. So I'd be interested in your views, but I'm particularly, I suppose the thing that's in my mind is the financial flows that are associated with digital interactions, both in primary care and in secondary care. So at the moment, we're still to a certain extent in a sort of emergency mode, and people aren't worrying too much about the money side of things for once in the NHS. But going forward, aligning financial flows to activity that takes place in a virtual way would be very important. Is that any part of the conversation at the moment? I know it has been, thanks to our friends Babylon, it has been to a certain extent in primary care, but what about in general?
I've not heard that that's a huge conversation point at the moment. I think it will be, we're still some months away from that really coming onto the agenda. I think at the moment the focus is very much just to roll out as much as you can digitally, and worry about the sort of cost later. I think, from speaking to a couple of trust and CCG leads, they've said that they've sort of enjoyed having almost enjoyed having the freedom to not think so much about the financial side of doing these kind of innovations. So at the moment, I don't get a sense that conversation about money and how we're going to align what we're spending with the activity that we're doing, how that's, how that is going to work. I think we're still maybe 6 to 9 months away from that. I think this financial year really is going to be almost sort of a write-off in terms of thinking about the money from the tech point of view. But then it will be interesting to see after that what kind of direction is given by the centre, by NHSX, in terms of the finances, because obviously it can't go on forever. But then I would have thought a lot of this tech isn't necessarily the most expensive tech to use. You know, it's not like we're talking about buying lots of new electronic patient record systems or electronic document management systems. At the end of the day, a lot of this virtual consultations are used just with, you know, simple video or telephone software, which really is at the cheaper end of the tech spectre.
Yes, that well-known piece of new technology, the telephone,
indeed,
has certainly been used a lot more. Just one final point on the technology. We saw a sort of basically national instruction to use the Attend Anywhere software for virtual outpatient appointments, which you know, I understand put a number of suppliers' noses out of joint. Are we expecting any other similar kind of mandation that particular services must be moved virtual? In other words, that you know, their expectation the expectation would be that these services would be delivered on a virtual way, and perhaps some kind of financial incentive would be given to do that. Or that there are any particular specific bits of software or particular types of software which you know, the centre is really pushing people to adopt.
I don't know. That's a tough one. I'm not sure I could offer up any meaningful guesses there. I haven't seen anything like the sort of major Attend Anywhere rollout in terms of other sort of types of software or pieces of kit or companies that we should be using. That seems to be the only one that's come at the moment. So I will have to just defer and say we'll have to wait and see, because I'm not sure I can think of any off the top of my head that would come anywhere near the rollout of the Attend Anywhere, for example.
Okay, well, again, if anyone has any ideas on systems that the service should be rolling out or is rolling out, then I'm sure Nick would be very keen to take your call or email or direct message. So just onto the final point of the editorial, just looking forward, if I put my sort of policy nerd hat on, which I never really take off, but let's talk a little bit about legislation. So if you cast your mind back to before the pandemic, there was a promise in the Tory party manifesto to introduce legislation should the NHS want it, and the NHS does want it, legislation which would facilitate the move towards integrated care. NHS England went through a consultation process and published some recommendations which the government more or less endorsed during the election process. Now, before the pandemic arose, we were expecting about this time to begin to see the draft legislation that would maybe have been introduced for the autumn term of the Parliament. Now, whether or that will still happen, we don't know. I believe that those at the top of the NHS hope it will still happen, and hope it will still happen to that timetable, but I think we'll have to wait and see. In the meantime, certain sort of the general thrusts of that legislation, a lot of it is sort of happening anyway, and the NHS England have been using the cover of the pandemic, if you like, to just get on with it. So, for example, as I say in the editorial, it's very clear that it is over for clinical commissioning groups. There have been a couple of brave attempts in HSJ lately to sort of suggest that CCGs were a vital part of the pandemic response. And while I don't for one second doubt that there are a number of organisation individuals who played a very important part, broadly they've been left on the sidelines. Their powers were taken away from them and taken up to a national level when a level 4 emergency was declared. And regardless of what kind of level we might move down to, they're not coming back. They are whatever the law might say. those powers will be fed through to developing STPs and developing integrated care systems, or the kind of leadership cells that are being developed in London and Manchester, for example, both of which we have written about. Now, again, this was happening anyway. Anyone who's reading HSJ will be fully aware of that. But a bit like the use of digital technologies, it just sped up. I think, and I'll finish on this point, Annabelle, what is interesting is whether the legislative reform, if and when it comes, whether it will be expanded. You see a lot of commentary on the Tory newspapers and websites and things, which I hang out on a lot because they're the government of power, talking about the response showing the shortcomings of the NHS as a bureaucracy. And there are two particular sort of things. One is the failure of the public health system. Now, we have known, for example, that Simon Stevens has expressed concern about the public health system long before the pandemic came out, and suggested that the NHS might just need to step in and do things that Public Health England and local authorities weren't doing. So we know this government likes to pull down on the NHS. Might we see public health return to the NHS's control? And talking of control, the other thing that gets talked about is establishing much greater direct control, a bit like, in other words, before the Lansley reforms, of NHS England by the Secretary of State. Now, that is a very double-edged sword, as everyone listening to this podcast will know, because if you're in charge, then you're responsible. But I think ministers and others close to the government may think, well, people are going to blame us anyway, so we might as well be in charge. And if we want to achieve the things we want to achieve, which are building things and hiring people, that's what they care about, because that's what they believe, with some reason, the public care about, as opposed to the more, shall we say, as they might see it, esoteric things that the NHS cares about, like outcomes, then better that we have direct control. And it will be very, very interesting to see whether legislation, if and when it does come, is expanded to allow them to achieve those goals. So that's it, Annabelle. That's my run through of what I've learned in the past few weeks.
Very good. A bumper edition of the podcast for everybody this week. That's fantastic. Thank you, Alastair. Thank you, Nick, as well. And I'm just going to remind all listeners that the HSJ Health Check podcast is available every week on the hsj.co.uk website and across all the main podcast channels. Please do subscribe and share and get in touch if there's something you'd like to see us talk about. Thank you so much for listening.